evening. Methodist welcomes you to the DEBAKEY CV Live Heart Failure Hour. So today we're going to talk about the elusive disease, sarcoidosis, particularly cardiac sarcoidosis. And joining us in the studio today is Dr. Barry Trachtenberg, my colleague and the director of our Cardio-Oncology program. From Virginia, we have Dr. Kron, who is a specialist at cardiac sarcoidosis, apart from her electrophysiology clinical work. She is a graduate from the Princeton University, where she graduated summa cum laude. She did her residency at Johns Hopkins and then went to fellowship at the University of Florida for both general cardiology as well as her electrophysiology. She's currently an associate professor at the VCU and also is very busy in her clinical practice. Apart from that, she is the editor on the editorial board on Journal of Cardiac Electrophysiology, as well as she does a lot of research in cardiac sarcoidosis, which is why we invited her to this particular session. She has grants from the NIH as well as the American Heart Association. Welcome, Jordana.
Thank you so much. I'm delighted to be here.
And from the comfort of his home joins us Dr. Al-Mallah, who is the director of our PET program and has since really revolutionized our cardiac sarcoidosis practice. Welcome.
Thanks for having me.
So I'm going to have some slides at the back, actually a lot of slides at the back, but we really want this session to be kind of interactive, and I want more and more people to join us from their homes. I know there are people watching us live. You can join us by web. If you go to pollev.com, you can enter the code DEBAKEY and then respond to activity, or you can join by text. Text DEBAKEY to 37607 and text in your message, and you can send us questions. So a brief overview of sarcoidosis. So it is an inflammatory disease. It is where you have abnormal lumps of inflammatory cells that accumulate, which are called granulomas. I'm trying to make it simple because we know that some of our patients will be joining us as well. Generally, it is a genetically predisposed disease as well, and there is a thought that various antigens can result in exposure, which result in the manifestation of sarcoidosis. Generally, it is a multi-system involvement. It can involve any number of organs, your brain, skin, eyes, joints, and of course the heart, in about 25% of the cases. It is a diagnostic challenge, mostly because it is a great mimicker. Why do we care about this disease is because it leads to poor quality of life and decreased workability, as well as increased mortality in our patients. So the objectives for today is we're going to go over prevalence and impact, how we diagnose cardiac sarcoidosis particularly, the management, treatment, and prognosis, and then areas of uncertainty. We'll be talking about a lot of controversial areas which are still under study, and we don't have many randomized studies to support the data. So as you can look at the charts for different countries, including Sweden and Korea and then Olmsted County data, the disease prevalence is highly variable. Generally thought that it's more common in African Americans, and it occurs either in later during the life or early. However, it can be highly variable. And what we've seen clinically is that it's not just African Americans, it can be any population or ethnicity. Don't you agree, Barry, that that's generally what we see? And Jordana?
Absolutely, yes. And also you can see by the graph that male, female predominance varies all by study. So it's definitely a disease that can affect many.
I think people typically think of sarcoidosis as a disease of African American women, but you have to have a high suspicion for this disease to make the diagnosis, which can be so challenging. So it's important to consider that this can also happen in people that are not African American and can happen in men as well. So we need to think about this disease so that we can make the diagnosis. While it's more common in African American women, that's not the only patient population that we see it in.
Absolutely. So in terms of organ involvement, I'm not going to go over all the details, but it helps to know that you could have eye involvement, neurological involvement, you can have pulmonary fibrosis, which is, of course, the most common manifestation, which is lung disease. And we'll talk a little bit about the heart disease part, but you could also have glomerulonephritis. So the burden of disease in this patient is pretty profound. And if you know of and can think of other organ involvement, I always do a very detailed review of systems in these patients because it can help make the diagnosis. And we will be going over the diagnostic criteria in detail. So why do we care as cardiologists? In this room, I have 2 heart failure cardiologists, an EP, as well as imaging. Well, the global sarcoidosis mortality is about 9 to 14 per 1,000 cases. But in patients who have cardiac involvement, their mortality is even higher. They also have a high burden of disease. In general, patients with sarcoidosis, even if they don't have, they're not undergoing treatment, they're at high risk of having infections, of having stroke, thromboembolic events. They can have other concomitant autoimmune diseases, as well as hematological cancers and solid organ malignancies. And the hazard ratio of that is as high as 2. As far as the cardiac involvement is concerned, they have a very high rate of heart failure, arrhythmias, and heart blocks. And it is becoming more and more prevalent as we are improving on our imaging modalities and more patients are getting diagnosed with this disease. In Finland alone, the rate of diagnosis of cardiac sarcoidosis was more than 20-fold between the years 1988 and 2012. Cardiac sarcoidosis can be the first manifestation of sarcoidosis in any organ. So, depending on which part of the heart is involved, that really depicts what kind of cardiac manifestation you're going to have. If it affects your conduction system, you could have AV block. If there is inflammation and scar formation, they can act as re-entrant areas where VT can emanate from. You could have heart failure. And interestingly enough, you could have valvular heart disease. We have seen patients who have had valvular inflammation, and as a result of that, they get mitral regurgitation or aortic regurgitation. And not to forget, one of the recent cases that we diagnosed had pericardial inflammation as well. Jordana, do you want to talk about the sudden death in cardiac sarcoidosis?
Sure, I'd love to. This data shown here is from a very important set of data from Finland, where they looked at 351 patients of cardiac sarcoidosis and looked at how they presented. The most common presentation was AV block, which occurred in 42%, which is shown over on the left side of the graph. However, sudden death was also a very common presentation. So it's important that we keep this in mind when patients present with VT or VF or complete heart block that can also be a life-threatening arrhythmia. When we look at the modes of death on the right, I think it's very important that sudden cardiac death occurred in 80%. Now we know that the arrhythmic deaths can be prevented in these patients with a defibrillator. A defibrillator, of course, has pacing capacity. And so this is really important to assess your patients for the risk of sudden death so that we can prevent it with our devices. Other modes of death like heart failure, post-transplant complications, or other non-cardiac causes were much less common than arrhythmic death.
And Barry, I'm sure you must agree that we've seen patients in various cycles. They might be very early, they don't have any symptoms. They might have some PVCs. Some patients may have sudden cardiac arrest and may require advanced therapies, and others who have end-stage heart failure. So it could be at any stage of the game that we see these patients. So the mechanism, as I mentioned earlier, it's the formation of non-necrotizing granulomas, and it is an inflammatory cascade, usually in genetically predisposed individuals who may have an exposure of some sort, and that results in the activation of the immune system, particularly the interleukin 17, and then they're on TNF as well as macrophages, and all of these can then form these granulomas. This is a pathology depiction of this granulomas. So, as a cardiologist or internist or rheumatologist, any physician can be the point person for these patients, and they can present in various different forms. So in terms of screening, Jordana, if somebody who has known history of sarcoidosis, how do you proceed with screening these patients?
So I think that patients who have sarcoid in any organ system should be screened for cardiac involvement. But the slides I just showed, because the risk of sudden death is significant, it's really important that we think about cardiac involvement. So anyone that presents to the ophthalmologist, to the dermatologic clinic, to pulmonary clinic, the doctor should at least raise the question of whether there could be cardiac involvement and either do the preliminary screening or refer them to a clinic that's comfortable doing it. Do you have that slide that shows, I think it might be the next slide, that shows the algorithm for screening? This one, perfect. So this algorithm was presented in the 2014 consensus statement from Heart Rhythm Society. That was really the first consensus statement looking at arrhythmias and cardiac sarcoidosis. So anybody with biopsy-proven sarcoidosis in any organ system outside the heart should be screened. I love this algorithm because I think it's very simple and it's not too expensive. So we should ask for a cardiac history focusing on palpitations, syncope, and pre-syncope. Look at an ECG focusing for any level of heart block, first degree, second degree, third degree, right or left bundle branch blocks, or any other abnormalities on the ECG. And then also do an echocardiogram looking for focal wall thinning or any LV or RV dysfunction. If any one of those three things is abnormal, symptoms, ECG, or echo, we should then go on to advanced screening with either cardiac MR or a PET scan. If all three of those are normal, the patient's very unlikely to have cardiac sarcoidosis. One of the things that's not known is how often we should rescreen patients. If you screen a patient for these and everything is negative, when should we look again? Well, there's been no studies to guide us on that, but I think it's very easy to do an ECG once a year and to ask the patient about symptoms. So I'll often see somebody once a year in my clinic just to make sure that nothing new has developed. It's also very easy to get an echocardiogram every year or so to make sure they don't develop symptoms of cardiac sarcoidosis.
So, Dr. Kron, what about people like our other guest, Dr. Al-Mallah, who might argue to, even in the patients that don't have any obvious abnormalities on echo or EKG, that maybe we ought to consider a one-time or once every several years PET scan or cardiac MRI? And maybe Dr. Al-Mallah might have a comment on that.
Yeah, so that's a controversial question. I think before we were like, when I was practicing in Detroit, we had a long list of patients who had proven pulmonary sarcoid, but many of them actually did not have cardiac involvement. I think it may be reasonable to lower the criteria for patients like who are having some palpitations or minimal EKG abnormalities or extrapulmonary sarcoidosis to at least get an MRI, I would say not a PET scan, on some of these patients at some time to confirm whether they have some cardiac involvement. Because the mechanism of these patients of the sudden cardiac death could be scar mediated or it could be active inflammation mediated. And if they have scar, I think that will put them at a higher risk and probably will require further attention by our colleagues in electrophysiology or heart failure.
And a lot of times the EKG may be silent. Do you agree, Jordana? How often do we see somebody who has inflammation but yet the EKG seems silent?
I think that can happen, but I think when we're talking about a cost-effective way to screen these patients, we don't want to just upfront do a lot of really expensive testing. I mean, I think that's the downside of just doing an MRI on everybody. We're trying to identify the patients that are likely to be low risk. And so if you don't have any symptoms, a normal echo and a normal ECG, your likelihood of having really high scar burden on MRI is low. I think it's not zero, but you're unlikely to have a really high scar burden.
With this, we're going to move on to our first case. So this is a 64-year-old female who's African American who presented to my clinic. Interestingly, her mode of presentation was that she brought her right heart cath report with her and told me that her cardiac index was 1.2. And her cardiologist didn't know what else to do with her, so he referred her to me. Interestingly, she had history of lupus and was on Plaquenil and methotrexate and was then intolerant to methotrexate and was taken off of it because of kidney dysfunction. She had already been on Benlysta as well for her lupus. In the last year, she had worsening mitral regurgitation and she underwent mitral valve repair for this. And after her surgery, she still didn't feel good, so she underwent a pacemaker placement and AFib ablation. Her symptoms included extreme fatigue and tiredness. She had extremely poor quality of life, and she was very highly functional prior to this. She had shortness of breath and minimal exertion, and she was admitted in the hospital at least 4 times in the last year. So this is her presenting EKG to my office, and this is a parasternal long view of the echocardiogram. As you can see on this echocardiogram, this is classic. Usually you don't get patients who have such classic findings, but we can see the basal thinning, and there is LV hypertrophy. Her LVEF was reduced, and her ejection fraction was 20-25%. With this, because her history was also a little convoluted, she had plaquenil exposure, as well as some neuropathy that she mentioned to me. The important differentials were amyloid and plaquenil-induced cardiomyopathy as well. We proceeded with doing some extra testing to make sure that this was not the case. I have put her cardiac MRI. Dr. Al-Mallah, if you want to talk about these.
Sure. So on the top row, for those who don't read cardiac MRI, are the Sunni images. So these are like similar to echo views, but obviously better resolution, as you see here. And you can see in the right atrium that there is the ICD lead there. So the image quality may be a little bit down because of this is done with the device there. You also see the pacemaker, the mitral valve, which is prosthetic there. And you see the metal artifact. But all in all, you can see some regional warm motion abnormality. But when you come and look at the delayed enhancement, the late gadolinium enhancement images, which is on the lower row, and that one, if it is black, then it should be normal, and anything that's white here indicates late gadolinium enhancement. So gadolinium is hanging there longer than it is, and you see it in different multiple planes. The same area that you mentioned, Mahwash, on the basal septum, where there is basal thinning. You see it also on the septum in its entirety, on the short axis, where it's like mostly on the right side, which is a common question we get asked, like, can we biopsy? Obviously, in this patient, she has an ICD, maybe a little bit more difficult. But if the late gadolinium enhancement is mostly on the right side of the septum, make it easier for access for biopsy. And I also see some late gadolinium enhancement in the left atrium, which is becoming a little bit more concerning in some patients, especially if they have atrial arrhythmias. So extensive late gadolinium enhancement, the differential is not coronary disease because you see it's coming from the epicardium to the endocardium, and it is not following a coronary territory, and there is some patchiness to it. There is also in the inferolateral subepicardial. So obviously the differential includes from myocarditis. We're talking here about sarcoid. It's a little bit unusual, I would say, for amyloid to look like this, because amyloid is usually more subendocardial diffuse, kind of late gadolinium enhancement, not that much focal, although in some patients you may get it at later stage where it looks like this. So I'm very suspicious, based on this case, suspicious of inflammatory cardiomyopathy, or myocarditis-like process, especially with the history of lupus. That could be also in the differential too.
So at this point in time, we also wanted to make sure that she doesn't have amyloid. We did do the kappa lambda ratio, it was normal. We proceeded with doing a PYP scan, which was in the indeterminate category. And then we did biopsy her. And her biopsy results were also indeterminate, so we could not get a fair diagnosis. So this was in the era where we did not have a PET yet. And then Dr. Al-Mallah joined our practice, and we ordered a PET scan on her. And this is her PET results. Dr. Al-Mallah.
Yeah, so on the PET scan now you see a different kind of images. So we're looking at perfusion images on the top row, and then we show FDG images. Now the FDG images, fluorodeoxyglucose, is trying to look at the metabolic activity, but we're not trying to image the myocardium here. We are trying to image the inflammatory cells that are infiltrating the myocardium here. So what we do is that we suppress the normal myocardial uptake by the dietary preparation, where patients will have a lot of free fatty acid in the serum, so they leave the fluorodeoxyglucose that we inject for the inflammatory cells. So when you look at these images, you see that there is a perfusion defect at the basal septum. That's a difficult area to kind of make that call. But if you look here on the the vertical long axis or the horizontal, you can see that the septum is a little bit shorter than the lateral wall. And when you look at the FTG images, you see that there is a complementary uptake of FTG. And if you remember in the MRI, this is the same area that had the late gadolinium enhancement. So it is telling me that what we saw as late gadolinium enhancement was partly maybe scarring, which we will see on follow-up if it resolves or not. But a lot of it may be also from the active inflammation from the inflammatory cardiomyopathy that you see here. So this is an area where this is kind of the highest pattern that we see in terms of diagnosis. We actually try to take, especially in cases that we're going to do follow-up, we try to take it to the next level and try to do quantification for these. So there are different ways. How do you read these FTG PETs? You can just look at the SUV or the intensity of uptake, so another non-technical term here. And you can also look at the area. And you can see here the blue here is the normal. And you can see all this area, which is very similar to what we saw in the FTG and the MRI. It's the septum, anteroseptum, and infraseptum that has the highest uptake, with an SUV reaching almost 7. And when we quantify the extent of inflammation, you can see it also by territory. So we can tell like how much in each segment that we see the inflammatory uptake here. So this is the uptake quantification. We think it's going to be very helpful in following up these patients, because not everybody is going to go from bad uptake to no uptake. There might be some regional, some graded response in some of these patients. And I think that's very important to follow up on these patients.
So at this point in time, Dr. Al-Mallah is also very kind. So whenever he sees any lymph nodes that have uptake, he does mention those to me. So we always try to get tissue diagnosis, and I'll mention those in the slides coming up about the diagnostic utility and different things that we can do. But we did send her for lymph node biopsy. And sure enough, on her lymph node biopsy, she did have non-caseated granulomas. We made sure that she did not have tuberculosis, so we did rule that out with doing a TVT spot. Because, as we will mention, treatment is immunosuppression, so we don't want to immune suppress somebody who has tuberculosis as a mimicker. So diagnostic tools, we have touched upon some of these things, but EKG is, of course, both for screening and diagnosis, and can be abnormal into up to 8% of the patients. But as we talked about earlier, it can be clinically silent as well, but it is a very useful screening tool, as Jordana mentioned. Echo could also be normal. Now, this case that we presented has somebody with very classic findings, but it could be completely normal, or it may have all the features of sarcoidosis, including the septal thinning and LV hypertrophy. It can mimic hypertrophic cardiomyopathy as well. And we can see other abnormalities, including LV and RV diastolic dysfunction. There can be regional wall motion abnormalities. And newer techniques, including strain, are now showing promise in both early diagnosis and screening of these patients, but it's not prime time yet. Now, biomarkers. ACE levels could be elevated in about 60% of the patients. I think I get very excited if I see an ACE level that's elevated, but usually the test result is disappointing. Doesn't mean we shouldn't order it because in some instances it is helpful. Other tests like neopterin and soluble interleukin-2 are being evaluated, and Jordana is doing a study which we'll mention in some of the upcoming slides, where they're also looking at some of the soluble biomarkers. And troponin may be elevated at the onset, but some studies have been shown to be normalized after 4 weeks of steroid treatment. But to be honest, we really don't use these to follow treatment or diagnose patients. CMR, usually there is patchy and multifocal involvement. Most of the findings that were mentioned by Dr. Al-Mallah in our patient's case, and usually involves the basal segment, but can involve other areas as well. And you could see transmural involvement as well as RV free valve involvement. Now, Dr. Al-Mallah, do you want to touch upon some of the prognostic values that, of CMR?
Yeah, so there have been multiple studies that looked at this. Here you see one of them, which looked at the presence of LGE, as we see in multiple other cardiomyopathies, has been associated with worse outcome. It has been associated with increased risk of ventricular arrhythmias also. And there are some centers that are using T1 and T2 mapping, which might be helpful in early cases where the patient did not develop a scar yet, but they might have some tissue composition changes and edema and others, and this is where T2 mapping might be helped too. So these are techniques that are in development and sometimes may help you make the diagnosis. Next, please. And FTG PET, as we saw in that prior case, what we are trying to image here is primarily those cells that utilize glucose. So we give them radio-labeled glucose, and we try to suppress the normal myocardium from uptaking glucose. So this way, all the FTG is taken by the inflammatory cells, which light up and will help us quantify it using doing the SUVs or tissue to background ratio. And it will be very helpful also in assessing response to therapy in these patients. So many of these patients may have 1 or 2 MRIs, but they will have, especially the difficult cases or the advanced cases, might have more than 1 MRI, more than 1 PET scan to allow for follow-up of the response to therapy. But in terms of algorithm, where do you start? I think, at least as someone who do both modalities, I would say always start with an MRI to confirm whether there is or not. And there are some cases where they are discrepant, but I think starting with an MRI has a better yield than starting with PET, because if the MRI is completely normal and the index of suspicion is low, then the chances of having a positive PET is extremely low in these patients. Next. And this is the preparation. I kind of quickly touched on it. And the preparation here is that we are looking at trying to suppress the normal myocardium. So this is one time where we tell our patients, we don't want you to eat carbohydrates, and we want you to eat high-fat diet for 24 hours before the procedure, and then fasting for 12 hours. And in our lab, we use heparin, try to try to increase the free fatty acid in the serum. There are additional protocols that are currently in studies trying to simplify this to make it easier for patients, because sometimes you may end up with a patient who did not follow the diet protocol very well, and you fail to suppress the myocardium. I don't want to call that study positive just because we failed to suppress the myocardium. So also, if this is where potentially the MRI can help you, because if there is no late gadolinium enhancement and you see diffuse uptake in the myocardium, that's more likely to be failed suppression rather than true positive scan. Next, please. But the most specific pattern is what you see here, which is similar to what we saw in our study in our patient, where there is a perfusion defect, as you see on the top row, where there is a perfusion defect in the anterior lateral and lateral wall, and there is significant FTG uptake in that area. Also, if you look at the fifth row, where you start to see toward the right-hand side of the fifth row, where you see the perfusion defect in the mid-anterior wall, and there is actually FTG uptake in the anterior wall, significant there. All of this indicating this is kind of the most specific, and in a patient with history of systemic sarcoidosis, that's almost diagnostic in this patient. Fortunately, we don't see this that much because these are the sickest patients who have a lot of arrhythmias and who tend to like have more of a stormy course. So these are the positive patterns, and the upper one, which is probably the most significant here. There are other patterns that are less specific. And when you look at the presence of FTG uptake, similar to what we just saw with MRI, also FTG uptake has been shown to be positive, to be predictive of future events in these patients, as you see here. I kind of quickly touched base on this when we discussed the case. How do you report these PET scans? It's very important whether we would like to go ahead and try to quantify the FTG, very important. And this is another study from the group at, I think this is from the review from the Brigham group, where they're looking at different patterns here, where you see the CMR. And the nicest thing is that to have a normal perfusion, normal CMR, that's a normal study. But then you have the different patterns, and the third row would be the most specific, where you have late gadolinium enhancement, you have edema, and you have also perfusion defect and FTG uptake in that perfusion defect. There are many other patterns that are less specific, but sometimes we need to look at them. For example, a patient might have on the row before the last, which is the scar pattern, where there is a scar that you see on MRI, but there is no FTG uptake in that area. So this is a patient who had a prior scar, had prior cardiac involvement, but there is no active cardiac involvement at that moment. These patients are probably going to be still at risk because they have a scar in their heart, but they're probably lower risk than those who have active inflammation. So these are patients with inactive sarcoidosis.
So this brings us to a little controversy. Do you all think that at this point in time we're ready to do just one modality, just CMR or just PET for our patients, both for diagnosis? I guess in one sense we could say that disease follow-up is probably PET alone, but for diagnosis and prognostication purposes, is one modality enough? Dr. Kron, do you want to comment on your practices?
Sure. I think at this point they're really complementary. It's really nice to have the MRI, which predominantly shows scar tissue with the late gadolinium enhancement. The PET scan, excuse me, is helpful because it shows ongoing inflammation. Now there's some potential with the MRI. There's some new modalities looking at T1 and T2 mapping that show edema and potential inflammation on the MRI. So there's potential for the MRI to give us a lot of the information that we need. But right now it really helps us to do both of them. I think in our clinic, the cardiac MRI really helps with diagnosis to see if there's late gadolinium enhancement in a pattern that's consistent with cardiac sarcoidosis. Clinically, the major use of PET scan is to help guide treatment. It's very difficult to know how active disease is in the heart with any other modality other than PET scan. Because the PET scan shows active inflammation, when we start treatment, we hope that that inflammation will either improve or really dissipate with appropriate treatment. So we use serial PET scans to follow up how we're doing with treatment, whether we need to escalate treatment or whether we're right on track and accomplishing our goal of quieting down that inflammation in the heart.
Dr. Al-Mallah, do you want to comment on the combined strategy and this one recent
Yeah,
paper?
I think Dr. Jordana just like really nailed it down. I think MRI has some potential, I think, but still, even with T2, it's like when you talk to different MRI operators, there's still a lot of subjectivity and there's a lot of variability. And even the T2 mapping is very close, very narrow margin. It depends where you get your ROI and how do you get your measurement there. So I think for the current time and the near future, I think we're still going to be depending on two modalities. I think in patients who have cardiac PET scan like the one that we saw, if for whatever reason the patient cannot undergo cardiac MRI, I think that one is like where you see a perfusion defect and there is a complementary FTG uptake in that area and a regional wall motion abnormality, and you have, for example, history of systemic disease, then you probably don't need additional information at that point because you know that the disease is there. But as someone who interprets PET, my life is much easier when I interpret the PET. If there is an MRI, I use it more of a roadmap, because sometimes the main problem with PET is the failed suppression, and you don't want to overcall disease unless you are sure. So you try to gather information from the MRI. You also look at the clinical pre-suspicion. The only probably a couple times where MRI might be negative, but PET is positive are if you have a complete AV block in a young patient where it's kind of sometimes very difficult to detect it by MRI because it's close to the mitral annulus and it's like very, sometimes maybe very small in terms of late gadolinium enhancement. The other area which may be concerning is very early in the disease where patient might have T1 or T2 abnormality, but the late gadolinium enhancement may not be positive yet in these patients. There are few cases extremely early in the disease, although later on, once you start to develop enough edema, then the late gadolinium enhancement will light up, because this late gadolinium is not only scar, it's scar and increased extracellular space from edema. So not all the late gadolinium enhancement that we see means scar. It means scar plus edemas, and that's why it's not. We try not to call it scar per se on reporting these MRIs.
So I guess at this point in time, I think we can agree that both modalities are additive value. We can start off with the CMR. Dr. Kron, you were saying something?
I was going to say another advancement that's hopefully going to continue to improve our ability for diagnosis and following patients is our ability to do MRIs in patients with devices. So now we know that we can safely do MRI in most patients with implantable devices, pacemakers, or defibrillators. There is still artifact that comes up on these scans, but there's new technology and new sequences coming out. A lot of research is in this area to find out how we can get really high quality MRI images even in patients with devices, and we're doing some research in that area to try to look at wideband sequencing and other imaging modalities to try to really get good images even when patients have devices. And I think that's something that's going to help us out going forward as well.
Absolutely. There are, of course, rare instances where I think even when the CMR is negative, we do proceed on to going to do PET. I think there have been questions from several physicians that are referrals to us whether they should be doing both CMR and PET, and I encourage them to do both at this stage of the game, because I think both imaging modalities have their own additive value. So next, we're going to talk about, the diagnostic criterion. Excuse me. So at this point in time, we have the Japanese Society of Sarcoidosis and the Heart Rhythm Society guidelines. And both of these are important to understand. So, of course, if you have the diagnosis from an endomyocardial biopsy from both the Japanese Society and the Heart Rhythm Society, the diagnosis of cardiac sarcoidosis can be made easily. However, Dr. Trachtenberg is going to talk about the yield of biopsy. So only 20 to 30% of the patients actually do have a positive biopsy. So what do we do with the rest? Because it is extremely important to diagnose if they truly have cardiac sarcoidosis or not. So then we talk about the clinical diagnosis. How can that be made? It is easier if they do have extra cardiac sarcoidosis. So let's say if somebody presents and they had a diagnosis of pulmonary sarcoidosis, like in our patient who did have a mediastinal lymph node that showed non-caseating granulomas, and then we can use PET and CMR and use these clinical criteria to diagnose cardiac sarcoidosis. In my mind, I find the Japanese Society of Sarcoidosis helpful in a sense that it is a little bit more detailed, and in the most recent update, they did make a PET and CMR a major criteria. However, the Heart Rhythm Society seems to follow the same kind of guidelines, but is slightly more abbreviated. But I'm going to break down the Japanese Society criteria because it helps me clinically, and I think we can go over some of the details of the major and minor criteria. So talking about the major criteria, high degree AV block and ventricular arrhythmias are a major criteria. On echo, if there is basal thinning of the septum, if there is LV contractile dysfunction with an LVEF less than 50%, if there is PET uptake, and if there is delayed gadolinium enhancement on MRI. These are all major criteria. If you look at the minor criteria, if you have a normal ECG, meaning ventricular arrhythmias, non-sustained, or PVCs could be on the minor criteria. If you have a perfusion defect on the SPECT, that used to be a kind of an old way, but that abnormality can be counted as a minor criteria. And as you see here, endomyocardial biopsy in the past used to be a major criteria, but now has been moved to the minor criteria from the Japanese Society. Some characteristic findings which I actually look for in every patient that is referred. So bilateral hilar adenopathy, high ACE levels, or elevated serum lysozyme levels. Not necessarily the lysozyme level, because I think it is more in Japan, they may look at that. I do send for soluble interleukin-2 for sure. And then in rare instances where patients cannot get the PET scan, gallium scans can be used, but are not in regular practice. A high percentage of lymphocytes with C4D to CD8 ratio of greater than 3.5 in the BAL fluid. So you have to become friends with all these different subspecialties. So breaking it down really, so if you have somebody who has suspected cardiac sarcoidosis, so look for major and minor criteria, greater than 2 major or 1 major and 2 minor. Look for systemic involvement, respiratory, ophthalmic, and skin. I send all my sarcoid patients for ophthalmological evaluation. I've had at least 2 or 3 patients who we could not biopsy, but they had characteristic ophthalmological findings. Then looking for whole body PET if needed, and then chest CT to look for the lymphatic shadows and mediastinal lymph nodes. And like I mentioned, Dr. Al-Mallah always tells me if there is a mediastinal lymph node that lights up, which we can then biopsy. So you can really break it down to systemic involvement with cardiac involvement. So in those situations, if you have an endomyocardial biopsy, you've made the diagnosis. So you have a histological diagnosis. But what if the biopsy is negative and you made all this effort and you did an endomyocardial biopsy and it's still negative? How do we determine if somebody has cardiac sarcoidosis or not? In that instance, it's a clinical diagnosis. So it can be based off, number one, if you do have a positive biopsy from elsewhere, and you have the 2 major or 1 major and 2 minor criteria, you've made the diagnosis. However, there are patients where there is no tissue diagnosis from any other organ as well. In those instances, at least the Japanese Society recommends that you look for findings very characteristic, particularly in the lungs or in the eyes. And if you have those very characteristic findings, then you can use the major and minor criteria and make a clinical diagnosis. Now, this is an area which is fraught with much controversy, but it is helpful to be that detailed yet important to diagnose these patients, sometimes even without a biopsy diagnosis. Now moving on to a much harder diagnosis, and that is an isolated cardiac involvement. Now again, if you have a cardiac biopsy that is positive, you've made the histological diagnosis. So we're happy. But if you do not have a cardiac biopsy that is positive, what do we do then? So in this group, the Japanese Society at least recommends that if you do have a very suggestive PET or MRI, then you can use 3 major criteria to actually make the diagnosis of isolated cardiac sarcoidosis without any tissue diagnosis. Now again, as I mentioned, this is an area of much controversy, but again, it's also very important to make the diagnosis because, as we'll mention in the later slides, treatment is important and is associated with how the patients will do in the future. Now, with this criteria change and including endomyocardial biopsy as a minor criteria compared to other diagnostic criteria, the Japanese criteria had a higher yield, so to speak, for making the diagnosis of cardiac sarcoidosis. Now I'll have Dr. Trachtenberg talk about the endomyocardial biopsy role. Dr. Kron and Dr. Al-Mallah, do you have any comments on the diagnostic criteria before we move on? I know this is an area of much controversy.
I think one thing that I'll probably add here is that imaging, at least from our end, it's one element, and you obviously have to have the overall picture. And the negative imaging study in a patient with high clinical suspicion should not rule out a diagnosis and maybe continue to look for that. Because we've seen some patients who have negative studies for various reasons, and yet they come up with the disease a few years later. So if the clinical suspicion is high, I would say don't stop at the clinical test and continue to dig deep for these.
I agree with you. I think that isolated cardiac sarcoidosis is a very, very difficult diagnosis to make. And there's other patients that we have that we attempt biopsy and we just don't have positive tissue, but the clinical story and the imaging supports it. So one thing that we have to do sometimes in clinic is discuss with the patients the likelihood that they have this disease, but we don't quite meet criteria. And in some of those patients, after a careful discussion with the patient and the family, we will offer empiric treatment and see if we can have them, feeling better, treating their presenting symptoms, but knowing that we don't quite have, any tissue biopsy supporting us. And that's very tough to do.
So I'll talk now about the role of biopsy in these patients. And for sarcoidosis, the main challenge with an endomyocardial biopsy, and we'll start off with a question that someone put in, which is perfect, asked, in the absence of a biopsy, can you treat someone based on imaging and clinical criteria? And certainly the answer is yes for that. We do, we do like to get a histological diagnosis if the data is not clear. The challenge with sarcoidosis, especially compared to some other inflammatory and other infiltrative cardiomyopathies, is that the patchy involvement it makes it very poorly sensitive to do an RV biopsy only. So it's been reported that a right ventricular biopsy is only about 25% sensitive, certainly due to the patchy nature and because oftentimes the inflammation and or scar is in the left ventricular territory. But I do think it's important to point out that the left ventricular biopsy is something that is feasible. And also it's really important to point out, because there's a lot of hesitancy to do biopsies in the community, even among cardiologists, even among some heart failure cardiologists, the concern that it sounds like a scary procedure to have a piece of your heart or several pieces of your heart removed and taken into pathology, but it is a very, very safe procedure. So you could see here in this first table, this is older data using a very rigid Stanford Cave Schultz forceps it's showing in 546 procedures, there were only 33 complications. Most of those were access sites or transient arrhythmias. There were 3 out of this 546 patients that had definite perforations. 2 of those died, so obviously, 2 out of 546, it's not a small number, but that, again, that's older data using a very rigid forceps. So you can see the table on the right tells me 2 things. One is that using modern, more flexible biotomes, it's extremely safe. And you can see there's, out of thousands of patients, over 6,000, over 7,000 patients, there were no deaths and very few major complications. So one, the point is that biopsy is a very safe procedure. 2, if you're able to do a left ventricular biopsy, there are certain advantages. But if you look at the potential complication rate of each one, certainly the rate of perforation is higher with the right ventricular biopsy but it's still 0.3% or less than 0.3%, and less than 0.1% with an LV biopsy because of a thicker wall on the left side. Whereas a chance of embolization to the brain with a transient ischemic event is not going to happen with the right ventricular biopsy. It can happen about 0.2% of the time with the left ventricular biopsy. So it's important to know what the risk of complications are, but overall, whether it's RV or LV, the complication rate is very low. But importantly, looking at the diagnostic yield, when we're used to doing RV biopsies for disease that's often in the LV or biventricular, this is from a large series from Italy showing over 755 patients that had suspected myocarditis or infiltrative disease or connective tissue disease. They had, 35% had only an LV biopsy based on imaging, 17.6% had an RV biopsy, and then almost half had a biventricular biopsy. If you do a biventricular biopsy, your diagnostic yield, this is in general, not just for sarcoidosis, but your diagnostic yield is close to 80% compared to 67% for those of which we only do an RV biopsy. So this is a case that we, from our institute, and my colleague Dr. Bhimraj published this. This is a case with robotic guided left ventricular biopsy for sarcoid. This is before Dr. Al-Mallah joined us, before we had PET scan, we were more limited, but this is a 44-year-old Caucasian woman. She initially presented with syncope and dyspnea on exertion. She had complete AV block on her EKG. Echo was really not very remarkable, normal systolic function. CMR did show hypokinesis and delayed gadolinium enhancement of the basal anterior septum and the RV free wall and the mid-anterior LV. And so certainly with the AV block and that MRI, we're certainly suspicious of sarcoidosis. She did have inducible monomorphic VT and had a defibrillator paced. And she had an RV biopsy that was negative. And she underwent a CT chest that didn't show any lymphadenopathy. And 2 weeks later, she came in and presented with VT arrest. The initial antiarrhythmic regimen failed, and she was planned for VT ablation. We wanted to give empiric steroids for her, but she had there were concerns for infection in her, and she also had a recent device. So this is an example where we actually used the Da Vinci robotic sheath, which unfortunately was no longer available, but at the time you can see how flexible it is, and we're able to get to parts of the ventricle that otherwise would not have been able to. So you can see we use electronic anatomic mapping looking at voltage. So patients with a less than 5 millimeters voltage indicating scar and or inflammation, you can see in red was the highest area of decreased voltage in the panel C. In panel A, you can see the biotome in the sheath, and in panel B you can see the biotome out of the sheath and about to take a sample. And this is this is an example. I don't know if we can hit play. Of doing the biopsy through the LV, of course, with the help of our EP colleagues to do the electronic mapping and cross the septum. We were able to diagnose her definitively with sarcoidosis only in the LVOT. It was negative everywhere else. And so that's, so biopsy can certainly help you when you don't have a definitive diagnosis. And I think it's important with sarcoid, we know that it's patchy and the yield of biopsy is not as high. But in general, for inflammatory cardiomyopathies, there is a lot of nihilism in terms of doing a biopsy. But I think it's really important to highlight, particularly if you look at the red autoimmune, you look at giant cell myocarditis, sarcoidosis, eosinophilic myocarditis. These are diseases that respond to specific treatments, especially immunosuppressive treatments, checkpoint inhibitors. It's really important to make the diagnosis for these diseases, and biopsy can really be important. So, and with that in mind, and I think it's also important that with our first case when the patient was concerning for having amyloid, if you have a biopsy that you think could be amyloid, could be sarcoid, and the clinical picture's not that crystal clear, if you have a negative biopsy, that almost definitively rules out amyloid and would increase your likelihood of sarcoidosis and would increase your comfort of treating empirically, certainly. So we'll talk about specific treatment options broadly, certainly immunosuppression, steroids, and other immunosuppressive agents. Guideline-directed medical therapy does have a role for patients with a reduced ejection fraction. Specific when we consider an AICD and pacemaker, and then of course for patients that don't respond to all these therapies, then we consider advanced therapies such as LVAD or transplant. And I think it's important to recognize that those are not excluded for anyone with cardiac sarcoidosis.
So again, back to treatment, and there's a lot of controversy about treatment in general. So the way we're going to do this is I'm going to ask our panel and talk about some of the controversial areas. So the first controversy in itself is, should we treat? There are studies that have shown that there is a survival benefit in people who undergo treatment versus those who do not, particularly people who have symptoms of have some kind of arrhythmogenicity or have heart failure. There are definitely some studies that have shown mixed data about the improvement in ejection fraction, but in general, if the ejection fraction does improve, we know for sure that there is reduction in AV block and arrhythmias. And there was definitely a study where it showed that there were people who were treated with steroids had improvement in AV conduction, and people who were not treated with corticosteroids, none of them improved. Dr. Kron, if you want to talk about that particular aspect of treatment.
Yeah, so typically we'll treat patients if they are symptomatic. I think it's very important to treat patients with high degree AV block with high-dose steroids, because we know about half of those patients will have improvement in AV conduction. And it's certainly beneficial to any young patients, really any patients, to have their own intrinsic conduction if we can restore that. So if patients present with AV block, certainly treatment is warranted. I think it's also important to consider early whether patients need a device. I think that's a separate discussion. But for AV block, we usually start with prednisone or other steroids because they act so quickly. We often start right off the bat trying to figure out how we're going to stop the steroids, how we're going to wean them down and get patients off them. The steroids, as we all know, have very significant complications and side effects, from weight gain to diabetes, high blood pressure, damage to bones. And so we don't like to leave our patients on high-dose steroids for very long if we don't have to. So working very closely with rheumatology colleagues in our clinic, we often will start steroid-sparing agents early. The most common medicine that we use for this purpose is methotrexate. It's been studied well in sarcoidosis. Patients tolerate it well, and it does a very good job at treating the inflammation. If patients can't tolerate methotrexate or it's not working, we often will use azathioprine as another option. So those are sort of our initial steps, our prednisone and a steroid-sparing agent, and then trying to wean off the steroids as soon as we can.
So the other aspect of controversy, who warrants treatment, and I think this is a little bit more clearer. We can all agree that anyone with AV blocks, ectopy, or arrhythmias, and LV dysfunction warrant treatment. The one area that I think we do struggle with a little bit is if they have advanced heart failure and their hemodynamics are really, really poor. And so the question always is there enough time to treat, or can we just move on to doing advanced heart failure therapies? Dr. Trachtenberg, do you have any comments on that?
Yeah, no, that's a challenge. I mean, certainly, someone comes in VT storm. I think, I would certainly, treat them aggressively and try to decrease what, it's not clear at that point if it's scar or inflammation, but you definitely want to err on the side of treating any inflammation that's there. So I think most patients warrant an attempt at treatment. I mean, if they're coming in with severe dilated ventricle, with years of sarcoidosis, and they're inotrope dependent or dependent on mechanical support, I think at that point those patients you might opt not to treat. But I think most patients we deserve a chance at treatment.
Right.
Since it's a specific therapy for the disease.
And at this point in time, like much areas of the unknowns, we don't really know who would respond to treatment and would improve their LV ejection fraction to a point where they'll be sustainable with life and not require advanced heart failure therapies. Because even after we've seen treatment, some people do not improve their ejection fraction, they still continue to get worse, and they still require advanced heart failure therapies, at least in our clinical practice. Now, Dr. Kron did cover some of the aspects of how do we treat. So there are steroids and other immunosuppressive agents, and she went over some of the steroid dosages and how we taper them off. I mean, this was from the JACC article, and here they recommend doing 3 months of steroids and then adding an immunosuppressive agent, and then going on to see if they do not respond after 3 months, then adding an immunosuppressive agent. But much like you, Dr. Kron, I think we do have the similar practice. We initiate steroid-sparing agents earlier. We're also trying to do reduction in dosages because, I think there's a lot of side effects that can occur with immunosuppressive agents, and we've seen some infections that occur. Now, you mentioned some of the side effect profile from different steroids, but as Dr. Kron mentioned, it's really important to have a rheumatologist on board and perhaps even an infectious disease to look at the profile of the patient. We regularly look for TB, do their CMV titers, and recommend doing influenza and zoster shots before we start any of the immunosuppressive agents. And particularly in this COVID era, it's kind of an unknown. I've had to struggle with some of our patients when to start treatment, particularly if they're concerned about the risk with COVID. Now, Dr. Kron, if you can talk about your study, the CHASM CS or randomized control trial, the first ever study on cardiac sarcoidosis, which is a randomized trial.
So this study is a brainchild of Dr. David Burney, who's a world sarcoid expert up in Ottawa, and I've had the pleasure to work with him for many years. And this is really going to be the first randomized controlled trial for cardiac sarcoidosis, and it's looking at the first initial treatment. So patients that have a positive PET scan and clinical cardiac sarcoidosis with symptoms will be randomized to 6 months of treatment. In one arm, they'll get prednisone for 6 months with a max dose of 30 milligrams per day based on weight. And in the other arm, patients will get methotrexate for 6 months, and during the first 3 months, they'll get weaning doses of prednisone. So I think it's 20, 10, and then 5, and then off. Just because the methotrexate takes a few months to really kick in and get to maximal effect. So that prednisone helps in the first few months until the methotrexate is acting. And we think both of these arms are going to be successful in treating inflammation, but what we really want to look at is the side effects and the patient quality of life in these different arms. And so this is going to take a while to do. We're actively enrolling patients. It's an international trial with providers enrolling patients from all over the world. But it's going to take some time to do, but we're hoping that at the end of it, we'll have a way to recommend to physicians, if you have a new patient diagnosis of cardiac sarcoidosis, that this is going to be the first 6 months of treatment. This is how we should start. So we think this is a really critical trial. It's very difficult to do research in cardiac sarcoidosis. The patients have often systemic diseases. They're very heterogeneous, and it's not that common of a disease. So much of the research that is published is case series and retrospective data, but we really want good data to tell doctors how we should best treat these patients. So I'm very excited to participate in this trial, and stay tuned for the results. It's going to be a little while, but stay tuned because I think this is going to be important.
And Dr. Kron, you were going to do some biomarkers as well, right, as part of this study, which would be helpful to the CS world at large, I think.
There's a separate study that I'm doing that has some HA and NIH funding where we're looking at interleukin-1 blockade. Now, interleukin-1 blockade has really never been studied in cardiac sarcoidosis, but we have some preliminary data that it may be playing a role, that interleukin-1 may be playing a role in granuloma formation. So this is a pilot study. It's very early, but we're working with the University of Michigan. We're going to enroll 28 patients and randomize them for 1 month to anakinra, which is an IL-1 blocker, or standard of care. And then at the end of that month, we're going to look at some of our biomarkers, namely C-reactive protein and interleukin-6, to see if there's any changes in these that suggest this might be a beneficial pathway to look at. This is very early data, but we're very excited to look at it and hoping that it's going to teach us where to go next.
Game changer, perhaps. So other things are choice of immunosuppression. I was going to just briefly touch on some of the agents that are used in different centers. Every center is different, of course. For us, we use either Cellcept or methotrexate, or azathioprine. Dr. Kron already mentioned azathioprine, methotrexate. And then the fear always is TNF inhibitors. Now, that is another area of controversy, where people ask whether we should be giving people TNF inhibitors or not. What is your opinion, Dr. Kron?
So the concern for TNF alpha inhibitors is that they may worsen heart failure. There was some heart failure study that looked at it and showed that some patient had declining cardiac function. So I'll tell you that we use infliximab particularly as a second-line agent. So if patients fail their initial therapy with prednisone and methotrexate, or prednisone and another agent, if their PET scan is still positive or they're highly symptomatic, we will go on to use TNF blockers. And we've had very good results. Our patients have done well. I think it does an excellent job at controlling the inflammation. We do watch for worsening heart failure. We haven't seen it a lot. There's an important recent publication. It's retrospective data from the Hopkins group and some other centers, including Columbia, that looked at 38 patients treated with TNF alpha blockers, mostly infliximab, but also adalimumab. And the patients did well. They were able to be on lower doses of steroids, and their ejection fractions remained stable. So we're a little hesitant to use this in patients who already have a very reduced LV function. But in patients that have a normal or mildly depressed LV function, we do use infliximab or other TNF alpha blockers, and we've watched them carefully. I think that's very critical, but we've had some good results.
On that note, like you said, there are just a few studies that are, of course, retrospective, like you mentioned, and they've looked at the safety in a sense. I mean, they're not randomized control trials. So in this talk, we cannot advocate to use them, but we can certainly say that there is a safety profile. They have to be watched carefully. There's certainly a risk of infections, particularly if you're using more than one agent. So I think that's also important. But the two studies that were done, one from Johns Hopkins, the other one from Baltimore, both of those studies did not report a big infection rate, and there were only a few patients that had worsening heart failure. So really, this is another area which could benefit from a randomized control trial. Now, some of the other things that some people ask, are steroids alone okay? And the answer to that is, I think, can be fairly well established that the relapse rate is higher in patients who are on steroids alone. So I think that is one thing. And how do we define remission? And that's also a question of that most people ask, but in our minds, of course, the remission is when they don't have any more activity on the PET, and I think that's a more objective way to tell. But the other things are prevention of ventricular tachycardia, if they have decrement in pacing, and if they have prevention of remodeling or improvement in ejection fraction. Those are probably some of the endpoints to look at. And should we treat after remission is achieved, Dr. Kron? That's some of the people ask that question. Should we continue immunosuppression? And there's a little controversy over that.
That's a great question, and we really don't have great data to guide us. I mean, that's one of the things about treating cardiac sarcoid patients is we're not guided by a lot of data. We tend to keep patients on long-term treatment. Usually we try to get them down to stable doses when we can. But we recommend patients stay on it. Now, we have some patients that really want to come off treatment, and we watch them very closely. We've had some patients remain stable, but I think really nobody knows for sure long-term if it's safe to come completely off treatment. So we usually recommend maintaining patients ideally on a steroid-sparing agent without any steroids if we can.
And I think our practice is similar. We continue with some low dose of immunosuppression long term, but certainly we've seen recurrence even on that if they come off of some of their usual dose. In any case, I think the role of FDG PET, of course, we've already talked about, and that we can be more quantitative about it too, and there are different mechanisms of doing that. This one study looked at the SUV max, which declined in patients who were initially treated on immunosuppression. And we briefly touched on the TNF inhibitors, so those two questions sort of answered. So TNF inhibitors are safe, and we shouldn't be scared of them in people who need it, particularly if they're refractory to other treatments. So this is the follow-up on our patient who was treated on 4 months of prednisone and Cellcept. Dr. Al-Mallah, if you want to briefly touch on the findings.
So compared to the prior image, you can see that the perfusion defect did not change on the third row, whereas the rest perfusion and the perfusion defect did not change, but the FDG uptake has significantly decreased. You may not even notice it very well. So go to the next slide, please. So that's why we kind of look at it on the black and white, where you can appreciate it better here, that there is still some FDG uptake, and this is where we go for quantification, because the SUV max here in this patient, and this is using a digital PET system, so the different numbers, but you can see that go to the next slide, please. Yeah, so when we look at our number, the prior time it was, the SUV max was 7, and here it's still 7, but the area has significantly shrunken here. So at least the patient is heading in the right direction. Obviously, we try to correlate it with changes in LV volumes, LV ejection fraction. So the extent of abnormalities have significantly decreased. And on the prior one, the extent was about 19%, and now it's only 5% from the entire LV. There is nothing in the anterior wall, nothing in the inferior wall, as we saw before. So we're trying to report now more the extent, the SUV max, and hopefully at one time one is better for predicting patient outcome.
So for this patient, the pre-treatment and post-treatment, as we can see here, we were still a little disappointed that we did not have complete remission, so to speak. So what we did was we did enhance the immunosuppression with Cellcept itself, and in follow-up scans she did have improvement. But for her, good news, her ejection fraction did improve. However, several months of treatment, we decreased her Cellcept, and we got her off of steroids, but then she had recurrence, which was pretty raging. And then we referred her to a rheumatologist to do a TNF inhibitor in that situation, and had to have a discussion with both the rheumatologist and the patient, because both came up with literature suggesting that TNF inhibitors could be harmful, and I had to really explain it to them that it should be okay, particularly if you have such rip-roaring recurrence, to use. And she's done quite well on the TNF inhibitors, and has the EF has remained normal, and the PETs have been negative for inflammation. Just briefly on the ICD implantation, Dr. Kron, if you could touch on that.
Sure. So the standard indications for non-ischemic cardiomyopathy apply to cardiac sarcoidosis patients. Anyone who survived cardiac arrest or has a very low ejection fraction, less than 35%, should get a defibrillator. But there's a few other things that make sarcoidosis patients high risk for ventricular arrhythmias. One of those is AV block. So it's a little bit different from how we usually think about things, but if a patient with cardiac sarcoidosis meets criteria for a pacemaker, they should actually get a defibrillator. So it's really important that we think about this diagnosis upfront. And the reason for that is we know these patients, even if they have a normal or near normal LV ejection fraction, can have ventricular arrhythmias. When you have the substrate for AV block, the patients also have the substrate for ventricular arrhythmias. So anyone getting a pacemaker, you really should probably get a defibrillator instead. There's other risk factors, including someone that we've touched on, like late gadolinium enhancement burden on MRI. The more late gadolinium enhancement you have on MRI, the more substrate you have for these reentrant arrhythmias. The exact cutoff for how much late gadolinium enhancement is enough is not quite clear. There have been different studies with different cutoffs. We think patients with very low late gadolinium enhancement are probably at low risk, but a significant burden is concerning. Similarly, we've talked about this earlier, scar burden on PET scan and FDG uptake on PET scan also suggest that patients are at higher risk.
So with that, we're going to move on to our last case and the last couple of slides, Dr. Trachtenberg.
Sure. I think we can, in the interest of time, we could skip the case and just go into the outcomes of sarcoid and transplant. And just very briefly, I think it's important to recognize that the incidence or the recognition of diagnosing sarcoid has increased. Certainly in the most recent eras, a lot of this is due to increased recognition and increased technologies such as PET and MRI. But in terms of outcomes for transplant patients, this is a UNOS database registry looking at patients without sarcoid versus sarcoid, looking at 1 and 5 year outcomes, and they're very similar. You can see there's no significant difference in survival or graft survival of the transplanted heart at 1 year or 5 years. So it's important to recognize these patients are candidates for both mechanical support and heart transplant. Sarcoid is one of the most commonly, if not the most commonly, misdiagnosis prior to transplant. This is data from Cleveland Clinic looking at patients that had specific diagnoses that were made when the heart was taken out of the body for a heart transplant and sent to pathology. You can see 2/3 of the cases that were misdiagnosed were due to cardiac sarcoidosis in the light blue. Really, in our Methodist experience, we've done 27 transplants for sarcoid. About 10% of our combined heart-lung transplants are to sarcoid. We've done several heart alone and many lung alone, and their survival has all been excellent. So it's patients can do well with sarcoid. There's no reason to withhold them from advanced therapies, and I think. Dr. Kassi is going to talk a little bit about kind of the multi-system approach. And
so in most centers, I think if sarcoidosis is such a complex disease that you have to have specialists from different areas. And on that note, we do have a question for Dr. Kron, which says that with this multi-system involvement, are there any best practice recommendations to coordinate care among different specialists?
Yes, that's a great question because it's so important to the patients. I think one similar experience we hear from a lot of our patients is they have so many different organ systems involved, they have many different doctors, and the doctors aren't talking to one another. So we have a group where we often see patients together. We have 2 pulmonologists, 1 rheumatologist, me. We're now having a neurologist and dermatologist join our clinic as well. And it really helps to centralize care for the patient. So sometimes we see patients together. Many times we're talking, multiple times a week to try to coordinate care. So I think it really is important, whether it's in physical space or virtually, to make sure that these patients have coordinated care because they really need it. They have a lot of different complex disease systems involved, and it's really tough for these patients to be managed. They require a lot of time and a lot of ongoing monitoring. And so a team approach really seems to work best for making sure that we're treating patients closely, watching for side effects, watching for infections, making sure the vaccinations are up to date. It's a big job and it requires more than just one expert.
Absolutely, and moving forward, our Houston Methodist Cardiac Sarcoidosis program, we have a multidisciplinary approach as well. We have electrophysiologists without whom we usually don't do our biopsies, and they're there for us. We have our rheumatologist and pulmonologist and hepatologist and neurologist and ophthalmologist. In our practice, we don't have clinic in one system, but we do refer to certain only practitioners who look at and are treating sarcoidosis more often than other people. And for referrals or for appointments, there's the number listed. This is our advanced heart failure transplant team. And what our goal is, like any other sarcoid program, is patient-centered care. So we really do cater to all their multiple different comorbidities, which is really important in the care of patients who have sarcoid. With this, we will address some of the questions. And one of the questions was that PET appears to focus on LV perfusion and inflammation patterns. Is it known how frequently cardiac sarcoidosis involves isolated LV or RV? Dr. Al-Mallah, maybe this question is for you.
So isolated RV can be seen, although most of the time the patients who have RV involvement will have some RV involvement. So we do see RV involvement, but just like to be isolated, probably less. And you guys could guide me on this, at least from your clinical. From the cases that we've seen, we see RV involvement, and now lately we've been seeing more and more of atrial involvement in these patients, both on right atrium and left atrium.
I think we do certainly see RV involvement. Rather, one of the mimickers for sarcoidosis, RV involvement particularly, is ARVD, which makes it very tricky because a lot of patients can be misdiagnosed as ARVD. Rather, they don't have ARVD, but they have sarcoidosis, and they can have those aneurysms as well that have come off from the RV, and they have this huge arrhythmia burden. So there are times where there is some crosstalk and there are some case reports, but I think it's important to distinguish the two. And I think this is where electrophysiologists really help us. One of the other question is about endomyocardial biopsy. Is it necessary? I think more than that, tissue diagnosis is necessary. I think we can all agree that you just don't want to treat a patient without knowing what the fair diagnosis is, because it could be other mimickers for sure. And as Dr. Trachtenberg earlier mentioned, not all inflammatory cardiomyopathies are the same. And there's a chance that this might be an infection, so it's really important to have some kind of tissue diagnosis. So in that situation, an abnormal echo, EKG, and cardiac PET, I think if everything else has been exhausted, then making that isolated sarcoid in a patient who has a very strongly suggestive history might be fair, but I think in that scenario too, you have to be very cautious in who to treat and who not to treat. Dr. Kron, do you have any comments on that?
No, I agree. We always like to get tissue when we can, especially when the patient is first presenting. Our go-to is sounds similar to you. When we do the PET scan and we see lymph nodes that light up, we go to our wonderful interventional pulmonologists who try to target the inflamed lymph nodes to get good tissue, and we've had very good success doing that. We do some cardiac biopsies, also trying to use electroanatomic mapping to target the low voltage areas that may be scar, but we like to try to get the safest biopsy possible, so we try to get lymph nodes or skin or even liver if that's accessible.
Yeah, and in our own biopsy experience, at least, we've had no major complications. We've done over 35 biopsies, and the yield, of course, is really dependent, and if you're doing both LV, RV, how much inflammation the patient has. I'm of the opinion that if you don't have active inflammation, you may not see the granulomas, but it's still, you know, we've done some biopsies with image overlay as well, where we can put the PET overlaying the fluoroscopic and see where we're biopsying from. That concludes our session. If there are any other questions, we're happy to take them, but thank you for joining us, Dr. Kron and Dr. Al-Mallah and Dr. Trachtenberg. This was a very interesting session.
Yeah, thank you. I think it was a great session, and thank you so much for our guest for joining, Dr. Kron and Dr. Al-Mallah.
Thank you for having me. It's really been a great talk.
Yeah. All right. Thank you.
Thanks for having me.